Good afternoon and good morning to you. You are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health in Public Housing. Thank you for participating in today's webinar, recognizing and responding to domestic violence and human trafficking in health center settings. We are very pleased and happy to have three outstanding panelists today. And before we get started, we would like to thank HRSA for the opportunity to present these very important public health topics to all of you. The National Center for Health in Public Housing provides training and technical assistance to health centers, specifically to those located in or immediately accessible to public housing, as well as other health centers of FQHCs across the nation. Before we get started, we have some items that we would like to talk. First, everybody is mute. So if you have any questions, you can either use your chat box or you can raise your hand to ask questions. We will have a Q&A session at the end of the presentations. Also, please don't forget to complete the post-webinar survey. That is a great opportunity for us to hear from you about the webinars and ways that we can improve them. The learning objectives for today's webinar are define domestic violence and human trafficking, recognize potential person at risk in a primary care setting, identify promising practices for assisting person at risk of domestic violence or human trafficking. There are in 2018, 385 FQHCs reported to be public housing primary care grantees. Are located in or immediately accessible to public housing, and they serve 4.4 million patients in 2018. Out of the 385, 106 are public housing primary care grantees, and they serve over 800,000 patients. So before we hear from our first panelist, we would like to have a very quick poll. The question is, are you currently planning or implementing prevention and intervention programs on domestic violence or human trafficking? Okay, 15 more seconds. All right, Vida, you can close the poll and let us know the results.
Okay, so 48% said yes, and 52% have said no.
All right, thank you so much. So this is a very good opportunity to hear from our panelists today. They are subject matter experts on these two particular topics, and we are going to hear first from Christine Pagliarulo. She has been a behavioral health clinician at Whittier Street Health Center since 2005. She was promoted to the Director of Behavioral Health Services in 2015. Christine moved to Boston from West Virginia in 1997 after graduating from Skidmore College in Saratoga Springs, New York. She earned her master's in social work from Simmons School of Social Work in 2001 and is a licensed independent clinical social worker. She has worked as a clinician in community health settings for 18 years with a special focus on the treatment of women and trauma. Christine serves as the clinical and administrative lead for the Roxbury Neighborhood Trauma Team and is a member of Whittier's Senior Management Team, Quality Assurance Quality Improvement Committee, Environmental Care and Infection Control Committee, and co-chair of the Narcotics Committee. In March 2018, the Crossroads Group recognized Whittier Street Health Center as the top scoring behavioral health services organization in their nationwide database in terms of overall patient satisfaction among organizations using the same standardized questionnaire and methodology. Without further ado, turn the presentation over to Christine.
Thank you, Jose, and thank you for inviting me to talk about promising practices for assisting victims of domestic violence in a primary care setting. I'm just going to start by talking a little bit about our health center and our population. Whittier Street Health Center is a federally qualified community health center that serves Boston's vulnerable urban populations. Whittier is accredited by the Joint Commission and recognized by the National Committee for Quality Assurance as a Level 3 patient-centered medical home. We began as a baby clinic, and we've expanded, very much expanded since then, to more than 40 different programs, eye care, dental services, physical therapy, behavioral health and arts therapy, a wellness institute, and also specialized clinics focused on chronic illnesses such as diabetes, heart disease, and HIV. The mission of our clinic is to provide high-quality, reliable, and accessible primary health care and support services for diverse populations to promote wellness and eliminate health and social disparities. We are located in a predominantly low-income community of color, and those who reside in our service area struggle with poverty, racism, a history of neglect, and feelings of community abandonment. To give additional data to describe the population in our service area, Roxbury, Massachusetts historically has amongst the highest rate of mental health hospitalizations in Boston, and Roxbury's chronically high homicide rate and community violence is reflected in high levels of post-traumatic stress and depression in the patients we serve in the behavioral health department. Whittier's Passageway program is our domestic abuse intervention and prevention program. Passageway is a program of the Center for Community Health and Equity. Whittier's Passageway program is operated by the Domestic Violence Program Coordinator, who serves as a member of the Behavioral Health Department. The program offers individual support services, including safety planning, crisis intervention, supportive counseling, resource and referral information, education, and advocacy. Whittier patients, employees, and referrals from the community can utilize the confidential services offered by Whittier's Passageway program. The Domestic Violence Program Coordinator is mobile, with the capacity to provide clients with the necessary emotional support and advocacy needed outside of the office setting. The program coordinator accompanies clients to court and to the police station when requested. A little more information is that funding for Whittier's Passageway program is provided by the Brigham and Women's Hospital through the Center of Community Health and Equity. As stated earlier, prior to 1994, no formal domestic violence program existed at Whittier. The need for the program emerged from an in-house initiative to reduce infant mortality and morbidity. The initiative screened all prenatal patients for domestic abuse, a factor that significantly affects infant mortality and morbidity. Whittier healthcare providers saw reports of domestic violence increase considerably with routine screening during the initiative. So if we asked the question, people were more likely to answer. When the initiative ended, Whittier sought funding to establish what is now our Passageway program at Whittier. And this slide, again, just talks a little bit more about the scope of the work. It's not just around the direct client care and advocacy, but the program coordinator provides a program overview, patient screening tools, and information on how to refer to domestic violence services during all staff training. This is conducted annually. Along with the screening information, employees are also taught procedures for documenting injuries, collecting evidence, and safety and confidential guidelines for patients and staff. This slide focuses on the guidelines, the referral guidelines. Any community member or employee may be referred to Passageway if they disclose intimate partner violence and would like support, they convey safety concerns regarding a current or past abusive relationship, they request information or education about IPV or victims' rights, they need assistance accessing systems such as court, police, housing, shelter, as it relates to intimate partner violence. If, they can be referred if they have questions about what a healthy relationship looks like, or if they're requesting information or assistance to support a friend or family member experiencing IPV. Important to highlight is that consent must be given before a referral is made. And part of our program, why it's so effective, is that services are free and confidential. Again, the idea that our advocate is mobile, for able to attend court, and also going to the police when safety planning is needed. And we're going to talk a little bit about how we define domestic violence. Our working definition of domestic violence, it's also known as intimate partner violence. It's a pattern of coercive behaviors where one person tries to control the thoughts, beliefs, and actions of a partner. While the violence may cause injury, it does not have to be physical. Domestic violence also takes the form of emotional, verbal, mental, sexual, and economic abuse. It is a public health issue and can occur in any relationship, regardless of culture, race, ethnicity, ability level, educational background, age, socioeconomic status, religious background, gender identity, gender expression, sex assigned at birth, or sexual orientation. Whittier requires domestic violence screening at all new patient visits and annually. This occurs in all primary care specialty clinics, including OBGYN, HIV, and behavioral health. All adolescent and adult women are required to be routinely screened for intimate partner abuse, particularly in OBGYN, at each visit annually or during each trimester of pregnancy. A standardized screener is located in the electronic medical record, the EMR. We do use EPIC here at Whittier Street. This slide focuses on the features of the screener and the questions that are taken directly from the standardized tool in the EMR. And it's nice because there is a prompt. We very much normalize why we ask the question. And because we are focused in a health center, we do absolutely want to emphasize that violence and abuse affects people's health. So we ask the question of how often does anyone, including family and friends, physically hurt you? How often does anyone, including family and friends, insult or talk down to you? How often does anyone, including family and friends, threaten you with harm? And how often does anyone, including family and friends, scream or curse at you? The answers are in a rating scale of 1 to 4. Anything positive is really sort of the red flag or the green light to refer patients directly to the passage program coordinator. The referral can happen via a warm handoff in having the program coordinator go directly to the medical office during the visit. If there's an immediate consultation need or a risk assessment needed at that time, or if it's preferred by the patient, a separate appointment with the program coordinator can be made. The program coordinator has a private office in the clinic and also has an assigned cell phone to allow for communication to patients via text messaging. And what is nice about the fact that the program coordinator is a member of the behavioral health department. The program coordinator attends the weekly hour-long multidisciplinary team meetings with the behavioral health clinicians, the high-risk case manager, and with our psychiatric nurse practitioner and psychiatrist for case consultation and collaboration. This serves to decrease the isolation and susceptibility to compassion fatigue, commonly associated with domestic violence advocacy. Additionally, the ability to refer clients directly to psychiatry or other behavioral health services without the barrier of long wait lists has provided the needed support to the program coordinator in treating a population highly susceptible to PTSD, depression, and substance abuse. Okay, and the next following slides are taken directly from the training that we have for health center staff. So this slide focuses on the possible signs of domestic violence in patients. All health center staff are given the possible signs of domestic violence to include injuries inconsistent with explanation of cause, multiple injuries at different stages of healing, patient hides injuries and minimizes their extent, if the partner attends appointments unnecessarily, if the partner is aggressive or dominant, controls the appointment, or refuses to leave the room, continued patient reluctant to speak in front of the partner, Patient appears frightened, overly anxious or depressed. Patient returns frequently with vague complaints. A high amount of STIs, pregnancies, miscarriages, and/or abortions, somatic complaints, injuries to head, neck, chest, breast, abdomen, or genitals, secrecy or apparent discomfort when asked about the relationship, and a delay between injury and seeking medical treatment. Just as important it is to look for the screening. In the screening, we do pay attention to our own ability to respond when patients do screen positive for domestic violence. Again, staff are trained to have some supportive statements. It's very helpful to know what to say. And these next couple of slides do include some supportive statements. We emphasize that it's so important to listen rather than just tell someone what to do. So some examples of supportive statements are, I'm concerned for your safety and this is why. I am willing to listen without judgment whenever you are ready to talk about it. I won't pressure you to talk about it. Your feelings about your relationship and partner are valid. You have the right to make your own decisions. Domestic violence is not just physical abuse. It includes emotional, financial, and sexual abuse as well. Domestic violence is prevalent and can happen to anyone. Support is available. Would you like to talk to someone today? You do not deserve to be abused, and this is not your fault. Another important tool that we talk about when we look at effective practices is recognizing the need to adopt a trauma-informed approach to domestic violence. Trauma-informed is not just what this slide focuses on, just about making sure that we have practices that recognize the physical, emotional, mental effects of trauma and victimization, but we also look as just as we help survivors increase their access to economic resources, physical safety, and legal support, using a trauma-informed approach means that we assist survivors in strengthening their own physiological capacities to deal with the multiple complex issues that are often experienced in accessing safety, recovering from the traumatic effects of domestic violence and other lifetime abuse, and rebuilding their lives. We really do focus on not just surviving, but on living. Ways that we can practice or adopt a trauma-informed approach to domestic violence is also discussed during our training, offering some insight into why it's difficult for some people to leave. Sometimes that's the thing that a lot of medical providers or even behavioral health providers or staff have a hard time understanding why people stay. And so this is also important for us to understand that our attitude or our behavior towards a victim or a survivor may also re-traumatize or stigmatize the individual. So we absolutely adopt a trauma-informed approach to domestic violence. And lastly, we are also given training on safety planning, and safety planning that, again, that a medical provider can talk or practice, or any medical staff. In addition to referring to the domestic violence program coordinator, we also do want our own suggestions and recommendations. So we document all incidents of the abuse. We take pictures of any injuries or destroyed property caused by the abuse. We try to help the individual pick a safe place to go temporarily as needed, pack a safety bag and store it in a place where your abuser will not find it in your home or give to a friend. Work out a plan with others to help when you leave. So again, these are just some immediate things that a medical provider or any medical staff should have in their as their suggestions when thinking about safety planning. And I know that this was a lot of information. I wanted to make sure I stuck to a time limit, so I will hand it back over to Jose, and thank you for your time. Excellent.
Thank you, Christine. This is outstanding, and thank you so much for the current information. It's really nice to hear about what Whittier is doing to address domestic violence and or IPV in the community. Thank you so much.
Thank you.
Sorry, thank you, Christine. Next, we're going to hear from Zara Marselians and Carmen Combe about their human trafficking program. Zara is the founder, president, and chief executive officer of La Maestra Family Clinic, a nonprofit federally qualified health center that serves 48,000 underserved patients every year across some of the lowest income and diverse regions of San Diego County, California. From her decades of experience, Zara created the La Maestra Circle of Care services, which go way beyond essential health services and address the full scope of social determinants of health. Zara is author of 3 advocacy books, a well-regarded speaker, international consultant, and dedicated board member on the advisory boards of health center partners at San Diego-based Clinic Consortium. Zara is also a fellow of the American College of Healthcare Executives, a graduate of the Executive Leadership Program at the Fieldstone Foundation and Robert Wood Johnson Foundation, as well as a Bureau of Primary Healthcare Leadership Program graduate. Zara is a candidate PhD in Leadership Studies from the University of San Diego and was awarded the Dean's Graduate Merit Scholarship from 2018 to 2019. Zara is fluent in English, Spanish, Italian, and conversational French. Carmen is a foreign attorney, member of the American Bar Association, former magistrate from Peru. She has served in the judicial power for 10 years as a family and juvenile judge. Carmen holds a master's degree in international law of human rights. She was a professor in 2 universities in Peru. Carmen has also worked for the United Nations, supervising the compliance of the rights of the prisoners in the detention centers in the northern part of Peru. Carmen is a prolific author, having written over 93 articles in newspapers in Peru, Los Angeles, and in San Diego, and has co-authored 2 textbooks regarding domestic violence and children's human rights. In the present, Carmen is the director of the Legal Advocacy and Social Department with La Maestra Community Health Centers. She manages the largest international human trafficking program in San Diego. Good morning, Zara and Carmen.
Good morning. This is Zara Marselian. Thank you so much for the opportunity to share some of the programs and best practices we have at La Maestra to help human trafficking survivors and other survivors of violent crime. I'd like to start off just giving a brief background on La Maestra Circle of Care. It's an integrated model based on the philosophy that there are various multiple needs that our vulnerable populations have based on or from previous adverse experiences in their lives. And so the human trafficked survivors are definitely in that vulnerability group because they have so many contextual needs that need to be met. So it's not just a trip to the doctor or a trip to the attorney. There are many supportive services. And this is an example of how how medical and non-medical social determinants of services need to kind of integrate and be available to these populations. So this gives you an idea of the different programs we have, specialty services, again, all created in response to the needs of the populations that access services through La Maestra's 14 different sites. One of the, I think, a great innovative response to working with vulnerable populations, and this cultural liaison program is very essential in case managing and keeping track of our cases for human trafficking as well, is always having staff that are culturally competent, meaning that they actually come from the same population group, ethnicity, background, experience. So they know how to really understand the clients. They can relate to them automatically. It removes any barriers of clients feeling, oh, gee, maybe they don't understand me, or I'm ashamed to say this because maybe they've never heard it before. So cultural liaison to us, the model, means it's not just regarding ethnicity, but it's also understanding experience and background and context. So that is a fantastic program that I think has worked, and I would suggest is best practices. Okay. I'll give you an idea of the patients and visits quickly at La Maestra. In 2000, at the end of fiscal year 2018, we're almost at 50,000 unduplicated users. But then the visits are like, over 200,000. I think now it's like 245,000, and that's just capturing the medical visits. This chart does not include the visits that La Maestra provides around the other social determinants like housing, food scarcity, economic development, transportation, translation, all of those enabling services. So we're going to start with providing a definition of human trafficking. There are several variations on this definition depending on what website you're looking at. If you're looking at Department of Homeland Security, you're looking at United States Department of State. This is a pretty good definition. So I'm not going to read it to you. You can look into it further. And now I'd like to turn it over to my colleague, Carmen, for a few slides and talk specifically about our, human traffic victims and where they come from.
Hello, this is Carmen. So yeah, Sarah, looking at this slide, what I can say is we receive victims from everywhere. Right now in our program, we have about 180 clients, and they come from 24 different countries. And the majority of our clients for the sex trafficking field are from Mexico, and of course it's because we are close to the border. And the majority of our labor trafficking clients are from Asia, Philippines, and China. But they can come from everywhere, and we can see that in the next slide. And this slide is telling us what are the transit countries. So, trafficking is an international crime, right? So it goes interconnect a lot with the refugees and how the refugees move around the world. And unfortunately, right now, the world is in a very difficult situation. And the political crisis in the countries and the refugee crisis and gender discrimination and poverty makes people move around. So I think we all know that people from Europe goes to Asia try to come to Europe, and some people from Africa travel 11 countries to get to Central America or South America. And sometimes in South America, as you may know, Colombia is the largest country with the displaced population in the world. So from Colombia to Ecuador is a big immigrant shelter, and they start hiring coyotes there to go to Peru and the frontier with Brazil. So all of these contribute to trafficking. Unfortunately, I'm very sad to say, but trafficking is worse and worse and worse every time. And then we are in San Diego, which is the busiest frontier, how you say that?
Frontier.
Border, international border in the world. And right now, like I said, again, the refugee crisis is in Tijuana, right, in the border. And California is one of the top states, and San Diego is in a very, very difficult situation because it's not only refugees, it's not only trafficking that are very well connected, unfortunately, but many things are going on in Central America with this caravan, and then trafficking happens all over around. And then I have to say something about what Sarah mentioned already, are different definitions about trafficking. For some federal agencies, it's an international crime, so it doesn't matter where the the traffic situation happens, they will get help in the United States because that's what the way they see as an international crime. Some others, unfortunately, and that's my personal opinion, they don't see the crime in that way. So if they want the trafficking to be happening in the United States, it's very difficult to help these clients because they will not apply for immigration relief. So, and we are going to be like in the limbo with them, and we don't know exactly how we can help them, and maybe it's going to be the same situation forever. So, do you want me to go through? Okay, La Maestra statistics, you have it in your screen right now, and I'm very, very proud to say we are the largest international trafficking in San Diego. We have, like I said before, 180 about that overall clients, and these 8 years working in the human trafficking program. And we are not only the one of the largest nationwide, but we are the number one nationwide with the LGBTQ population as a survivors. And I'm very, very happy to say that, very proud, because this is, we are not only helping, but we are rescuing new lives and offering them something new. They come from many places. You can see the countries there. We still have to put more countries. That's why it says other at the last. But we are, I think, having right now for 24 different countries. And what I can say is we are only mentioning here 3 types of or forms of exploitation or trafficking, but they have many other categories under the umbrella of sex or under the umbrella of labor.
Okay, go ahead.
Now, in this statistic, is that the same?
Yeah, that's kind of the same, except that you have the transgender there. Go back, Mike, please.
Yeah, it's, you can see sex trafficking is the most. Most of them are women, but doesn't mean that all of them are females. We have also male victims of sex trafficking, which is very interesting. And labor, the majority of them are men, but lately we have many women in the labor program. They are still with open cases, and some of them are in both sex and labor.
And so maybe to give an idea, Carmen, you were describing before, the subgroup under labor for women always happens usually to be domestic servitude, bondage, and so forth.
Domestic servitude is a very interesting category because domestic servitude is not only trafficking, but many times is intimate partnership violence, and many times it's also domestic violence.
Yes.
So it is very interesting, important for people to know that is not only one crime, many times interconnect.
Sure, it's all interrelated.
With many others, and it's very interesting to know how to identify them, because after we identify them, we can find out the best way to help them. Okay, so what is next?
So speaking, as we were earlier, about the integrated model in response to multi-dimensional complex needs, as Carmen was just describing, it's like how when clients or patients come to any one of our programs, what our staff are trained to do, and this is something that is a recurrent training all the time. It's like mental health emergency training, human trafficking training. So domestic violence and many other very important training, staff development, for them to recognize what some of the red flags are. So I'm not going to read it to you, but you can see here many of these, and the next slides are real indicators that the providers or the directors of those programs, let's say if it's one of the social determinants programs, should be on the lookout and be able to identify and then immediately take action. Our staff isn't just trained on how to recognize or what are some of the signals, but then what? what's the process to do a warm handoff, to make sure that we don't, forget about these patients or clients, and make sure that we right away connect them with the appropriate unit, which in this case is Carmen. And so if the patients can feel, if they're coming from the clinic or if they're coming from one of our social determinants programs like housing or economic development, the director there is very, they know that they need to really quickly make sure that the patient or client is referred over to Carmen in a way that is non-threatening. And, they often accompany the client over to your office, wouldn't you say, Carmen?
Yes, yes.
And so the client right away knows, okay, great, I'm still within La Maestra's, umbrella here. I know I feel safe, coming to this unit. So, oh, wow, I'm now going into another unit that La Maestra runs. And so, right with Carmen. And so I'll let you go ahead.
Yeah. Well, I maybe want to make a comment about a couple of things. One day I was in my office, then the director of pediatrics called me. I went down to the second floor, and he has already a private office where I can speak with a woman that was kind of in crisis, crying and didn't know what to do. So something that I want, everybody who's listening, understanding that we don't refer people out. We don't say, call this number. We don't do that. We help them in the moment when it's in crisis, when she really needs or he really needs help. And the other thing that I can comment to you is one day a doctor from OBGYN also contacted me in private, and she said, I have a woman here that something is going on with her. Can you speak with her? And the woman was willing to talk. So we transferred the woman for the back side of our offices, where it's only employees side, and the guy who was waiting in the lobby, in the waiting room, didn't see that. So she was able to tell me some things, and the doctor was enough, she had enough knowledge and the trauma-informed care to find out that she was going to many abortions before. So that's what the warning sign that we were able to help. So this is something that I can comment to.
Thank you very much. And that's also, I want to say that in Carmen's case of the pediatrician who called her up, if our primary care providers do not screen for social determinants, a lot of these cases and signs aren't going to come out. The first case I think that Carmen was describing here of the lady who was, upset. She brought her kids in for the pediatric visit. Before the pediatrician found out and could connect that there was human trafficking going on with this case, with the mother of the two kids, he first got through, okay, well, the woman's been living in her car for 2 years with her small children. The children had chronic asthma, and, of course, going to the emergency room, and then they just give them standard antibiotics and standard course of that, and it doesn't seem to get better. And, without then drilling down why? Well, because of the housing situation. And then, okay, so then why was she living in her car 2 years? Well, because she was trying to escape from her husband who was trafficking her. Ended up being just an incredible nationwide case involving the trucking industry. Anyway, go ahead. So this is more barriers of why people don't step forward more often, because of these fears and because of, a lack of ability to sustain themselves and in most cases their children. Okay, more barriers, keep going, more barriers. So what services do we provide at La Maestra for human trafficking and domestic violence survivors? Intensive case management, of course, like we spoke about before. I think that, for human trafficking in Carmen's department. She does an incredible case management. She's got a lot of records. She has to immediately write down everything. We partner very closely with USCRI, which is the United States Committee on Refugees and Immigrants. And so of course they have their forms that they would, that they want us to use. We have our own case management, and it just takes up an incredible amount of time to be able to keep track of people as they're navigating this pathway through behavioral health, medical services, mental health, legal assistance, immigration, and everything. So you can see the different programs here, and then some really, I think very pertinent, very helpful services like the confidential address program Carmen's going to talk about, and the free phones that we've been providing our victims as well for the human trafficking and domestic violence.
Yes, Sarah, like you said, we have many, many services, but I want to add something here. When you work with victims, you work as an advocate, right? Mm-hmm. But if you pay attention, there is no college or university who has this advocate as a career. So advocate actually is somebody that wants to help people, loves to help people, has the passion, understand the human rights, understand equality and all that kind of things. But you can have any background. I mean, it doesn't matter. It's just that you want to be an advocate. Now, when you are an advocate, you can go through all of this list of services, but maybe there is a service that is not in the list that we still provided because it's case by case. When you work with people, you have to be creative. If you don't have it, you create it. Use your imagination, but try to help. We need to coordinate. Of course, we coordinate everybody, all the departments in La Maestra. And I'm very happy to say, so grateful to say that we have almost everything there. I mean, I don't have to go out to look for, but if I have to go out to look for, we collaborate with many organizations, right? Now, about the Safe at Home program, we are an authorized agency. This Safe at Home is a state program. It's in Sacramento, and it's a confidential address. So through this program, we are able to enroll people, and they will be safe. And depending on the case, they are great help because sometimes they are willing to pay for the relocation of the victim in order to be safe. And they are willing to pay for some, housing situation or for a big medical need that is not covered by medical maybe.
Okay, thank you. Go ahead. So Carmen was speaking about the trauma-informed care for medical services. This is super important. Our providers have gone through incredible trauma-informed care training, and it's a continuous training, continuous updating for many of our vulnerable populations, including those that, have multiple vulnerabilities. So for example, as Carmen was referring to, we're on the border. La Maestra was the first responder to the migrant crisis at the border, and ICE was dropping the migrants, the asylees, into our downtown area while they were waiting to then connect with their sponsor. Well, a lot of them had not accessed any medical services from the time they left their country of origin, which could have been how many countries ago, and taken this long journey with many adverse experiences and traumas. So this was their first time to connect with a provider. Well, you can imagine how many needs they had and how many, traumas, including human trafficking, including domestic violence, child abuse. I mean, a lot of other issues on top of the incredible need for medical services, mental and behavioral health, and of course, immigration and just tons of services. So that's really important to recognize the complexity of need and be able to have staff that are trained to be able to not only recognize, communicate effectively, be reassuring, and have the connections that we need to be able to send the children to Rady's Children's Hospital, or to contact Casa Cornelia for specialty immigration application services for political asylum. There's a lot of networks that La Maestra has developed over the last 30 years that then our patients and clients can access for the needed services out there in the wider society. Okay, so these are some of the other services. Keep going. I know we're running out of time. Collaborations, that's another huge lesson learned. I think partnerships, having partnerships and having a formal, informal kind of memorandum of understanding or some kind of, some kind of agreement in terms of what our collaborating organizations that we work with, what are they going to do? What are we going to do? I think it's really important to clearly identify those duties. That way, none of the clients are going to fall through the cracks. The more we can outline it and delineate it, the better off the structure is, and those pathways that we have to rely on oftentimes in emergency settings. We want to be very clear what everybody's doing. So there are just incredible opportunities out there. I think that this is one of the fields that, I was surprised to learn back, 10, 12 years ago when we were involved with the bilateral corridor human trafficking group, and to find that many perpetrators actually were trying to attend these community meetings, pretending that they also were interested in helping to combat human trafficking, when in essence they were there trying to learn what's new to get around it. They were one of the trafficking organizations. And to recruit. It's just amazing. So that's another huge lesson learned. Be careful who's at the table. Be careful who's coming to, because they want to help. If they're an individual, I would be very, very careful with that. I've seen it happen. So, and of course, in your community, if you know the churches, the faith-based organizations, and the ethnic-based communities as well, organizations, those are the ones to really be, to reach out to and to see, what's happening in their community, in their respective communities and their populations, and see how you as an FQHC can connect, not just for medical services, but also around some of these other social services and, unfortunate challenges that our society has now, and as Carmen said, in this age of global migration. So thank you very much. Is that it? Yeah. Oh, see, we were leaving you with some of these cases.
Okay, I just want to add a little something about what Sarah was saying before. We are very proud to say that we have this excellent collaboration with FBI. So when the clients are willing to talk about what happened with them, we don't have to bring our clients to FBI facilities. So FBI agents, they come to La Maestra to interview our clients, which is something amazing because the clients, they feel comfortable and they feel safe. And of course, many times I help them with the translations and interpretation. And the other thing, when Sarah was mentioning about the amazing services that we have here, I don't know if you remember in the previous slide when we were mentioning about the healing classes. And that's something very, very important because the program that we have for the clients is for 1 year. So in 1 year, can you imagine, it's a challenge to me to prepare them to start with a new life and how to fly by themselves. So in this microcredit program, we help them We train them how to, do they take the sewing classes, or they take the floral arrangement classes, or cooking classes.
Printing.
So yeah, printing. So they can start the business, the small business themselves, and try to survive until immigration will give to them an answer about immigration
Their visa
situation or visa. So that is something very important, because it doesn't make any sense to have somebody and help them if at the end of the day you will let them go with nothing. So we prepare our clients for the life in the future.
Yeah, that's an excellent point. I think that's really super important, is to be ready with what are some options that are that are feasible for the future, and how do you get people into those training programs, and so they can get their certifications and then get into the field that they're interested in working. Like we've had many cases where people will be going to, survivors go to the adult schools to get the certifications for chef assistants, or many other similar, certifications in the food industry, and just a variety. And I think that's really important, is to help them, access those pathways that we've established with, even programs that are, in the medical field.
Yes.
Yeah.
Mm-hmm. Yeah. Well, I think it's because of the time, but we have many other services that we didn't mention are in the slides, and I hope you, the audience, will have time to read it. We didn't mention, and we didn't talk maybe about the expungement services that we also provide to the clients, and the name changing.
That's really
for our transgender individuals. Well, we have a case in the screen right now. This is a very, very difficult, sad case. This happens in Tijuana. When this woman was about 11 years old, she went to this attraction park. How do you say that?
A theme park.
A theme park. And when her parents went to the car to do something, a couple approached to her and her sister and said, "We have stuffed animals in the car, so you want to come with us? I can buy you a candy, whatever." And they kidnapped them. They took them, transported to San Diego. They crossed the border with the two little girls, and they put them to work in prostitution when they were about 11 or 12 years old. And drugs were involved, like you can read in the screen. I'm trying to make it faster because of the time. And so they were separated, and if I am not wrong, I think she never get together again. So Olga is the name. She was in this prostitution, in the forced prostitution, for a long, long time, until she was rescued. She's one of our cases, and she's doing kind of okay, but because you can imagine, emotionally, somebody who was for so many years in prostitution, since she was a little girl, will maybe never be okay.
Well,
stable,
right. So then you're looking for coping skills, building resilience.
But the good thing is she has a visa now, and she was not able to find her sister, I'm not wrong, but overall she's doing well, and she's willing to talk when we have meetings and
support groups,
testimony of what happened to her.
Support groups have also been, I think, a good thing to mention for best practices.
Yes. So
I think we better stop here. Please, we encourage you to look at some of the other cases. I've also included a link at the end, which was a fantastic video that we were able to co-produce and have different collaborating partners, including FBI, the Public Defender's District Attorney's Office there, giving their input and weigh in on what the issues are around human trafficking and how we work together. And please send us any questions you have if we run out of time here. Thank you so much for your attention. This is an honor to be able to present. Thank you.
Thank you so much.
Thank you so much, Zara and Carmen. This is fantastic. I really, really, really enjoyed your presentation. I would like to thank the three panelists that we had today, Christine, Zara, and Carmen. Thank you so much for what you are doing to address domestic violence and human trafficking. I believe that, as it was mentioned during the presentations, these are public health issues, public health concerns that we need to keep in mind when we have contact with our patients. So we are going to start our Q&A session. You have any question for the presenters, please type your question in the question box, or you can also use the raise hand icon, and your line will be unmuted. Do we have any questions?
Currently, we don't have any.
All right, I do have a question for Christine in the meantime. Christine, how many patients do you serve through the passageway program every year?
Well, obviously it varies year to year. I mean, the numbers are in the hundreds, but we don't have a hard number at this time, because it fluctuates during certain times of the year, and that usually is something that's reflected in our behavioral health department as well. One thing that is also to emphasize is passageway data is separate. It doesn't go into our electronic medical record in Epic. It's in a separate passageway, I guess, a portal. So those numbers are not something that I monitor, monthly, but it's the domestic violence program advocate is part of our team meeting. We usually do, again, idea of how many people, but it's one advocate. So working with that number of patients, it is a very full-time, busy job for the one advocate we have.
Thank you, Christine. And one follow-up question. On one of your slides, you had a screening tool. Is that something that was created by Whittier, or is part of another SDOH tool that you use?
It's part of the EMR, the electronic medical record system we use is Epic. It's an electronic medical record system that a lot of health centers in Boston utilize, and I think it is nationwide. So it's a standardized tool that is in the system. So we did not create it. Yes.
Thank you so much. Now, for those looking for the slides will be sent to all the participants after the webinar is over, as well as the video that La Maestra included on one of the slides. We will be able to send that video when the presentation or the webinar is over. Do we have any other questions, Fide?
Yes, so we have one question, and I believe this is for Christine. It's from Ashley Thomas Mason. Is your IPV screening tool a specific tool, and if so, what is the name?
I think that was also the question that I think I might have answered it with Jose.
Yes.
The initial screening that we use in the electronic medical record, that is something that Whittier did not design. That is a standardized, those 4 questions were standardized in the social determinants of health screening that all patients are given, and that again is through Epic. We do have other screenings that either a behavioral health clinician can use, or the domestic violence advocate has showed us different tools. One is the HITS screening tool. That's another one that exists. That is not built into our electronic medical record, though. So for us, the fact that those 4 questions are ones that the comfort of any medical provider, it seems to be those questions with that prompt, are good conversation starters and good screening tools. But there are more in-depth ones, and again, the one off the top of my head I can think of is the HITS screening. I hope I have it right. Yes.
Excellent. Thank you so much, Christine. Any other questions?
Yes, we do. So we have one more from Glenda Wright. I believe this is for La Maestra. I work with single moms living in federally subsidized housing. Are they subjected to trafficking? I want to present this to TEL in a workshop. Thank you, Glenda Wright. Empowering Single Moms, Inc.
Yeah, this is Zara. I would imagine that that's a wonderful building awareness activity through, some kind of community awareness program that you could bring to those, to the housing, residents. Definitely low-income housing, single moms, is definitely something to build awareness around. We also have programs of this that we bring into our schools. La Maestra is in 4 schools. So, of course, you have to tailor it accordingly, and the curriculum has to be appropriate. But any of those settings where you can have access to people that might be falling into these unfortunate situations, you definitely need to bring the program. Thank you.
Thank you, Zara. Any other questions, Peter?
No, not at the moment.
All right. I just have a final question for La Maestra. Looking at the IPV presentation and the human trafficking presentation, it's very difficult for a clinician to distinguish who is an IPV patient or a human trafficking patient. And I understand that La Maestra has the outreach program, specifically the use of cultural liaisons. Do you train cultural liaisons to identify potential human trafficking patients, and so they can refer patients to any of the clinics?
Yes, actually, all of our promotora programs, our promotoras, are cross-trained to be able to identify, to speak out in these different community settings, health fairs, events that we have with our managed care partners and so forth, out in the communities. And so when people will come up to them and say, oh, well, you do have this, or, oh, yeah, this is my story, they'll be able to identify and make sure that they understand that they need to connect that person, make that appointment, call the director of that corresponding program where they think that this patient or client needs to be seen. And if it's human trafficking, domestic violence, as long as those connections are made and help navigate that patient through those pathways to get the help that they need, it comes from all different activities that we have. So the answer is yes, all of our staff is cross-trained.
Sarah, we also have very often conversations with the community, with the different groups of the community. And we also have flyers in different languages that help people to identify victims of crime.
And we've had transgender, some of our transgender victims actually go and provide training to our doctors during their provider training sessions in terms of how to be sensitive and culturally sensitive to the transgender community.
Mm-hmm.
Excellent. Thank you so much. One more time, I would like to thank Christine, Zara, and Carmen for these wonderful presentations. And thank you because you are offering your subject matter expertise so others can look at your resources and your evidence-based practices. Thank you so much. For those attendees, please join our mailing list and receive information about public housing and public housing primary care. Visit our website where you can find different resources, including webinars like the one that we are right now. And this webinar is recorded, so you can access it and go to our website and access the webinar. You can also follow us on social media, Twitter, Facebook, our YouTube channel, and LinkedIn. And if you have any additional questions, you can contact us at any time. Once again, please complete the post survey. And one more time, thank you, Christine, thank you, Zara, and thank you, Carmen, for these wonderful presentations. Have a good afternoon.
Thank you very much. Bye.